The present strip is obtained from a 67-year-old female, with prior history of hypertension and dyslipidemia, presented with generalized weakness and retrosternal chest pain since 2 days ago. What do you think about this strip? Which of the following is the correct answer? 1. Sinus rhythm with first-degree heart block and left bundle branch block. 2. Sinus rhythm with neglected inferior myocardial infarction. 3. Sinus tachycardia with 2-to-1 heart block and neglected inferior MI. 4. Sinus rhythm with inferior LV aneurysm. What are you going to do for this patient? As usual, to interpret every electrocardiogram perfectly, use the 10-step approach. First, start with standard values. The calibration marker measures 1 large box in width and 2 large boxes in height. So, this is a standardized 12-lead electrocardiogram. Next thing is heart rhythm. There are uniform P waves with positive polarity in inferior leads and negative in AVR, so the P waves are sinus. Red arrows are pointing at the P waves. As you see, alternating P waves are non-conducted and superimposed on T waves, so the ratio of P wave to QRS complex is 2-to-1. The PP interval and RR interval are stable, and about 2.5 and 5 large boxes respectively. So, the atrial rate and ventricular rate are 120 and 60 beats per minute respectively. Thereby, this is sinus tachycardia with 2-to-1 heart block. As a general rule, we are supposed to scrutinize all 12 leads to identify P waves. In this strip, non-conducted P waves are not detectable in most leads except V1. If we don't pay enough attention, we might miss non-conducted P waves and mistake the rhythm for normal sinus. So be very careful when interpreting heart rhythm. Third step is calculating heart rate. The underlying rhythm is regular, there are nearly 5 large boxes between consecutive R waves. So, heart rate is about 60 beats per minute. Then we should go through the heart axis. The QRS complexes are positive in D1 and negative in D2, so the axis is deviated leftwards. Next is examining wave morphology and intervals. As we said, there are sinus P waves at rate of 120 beats per minute. The amplitude and duration of P waves are 1.5 and 2 small boxes respectively that are within normal ranges. Additionally, alternating non-conducted P waves due to 2-to-1 heart block are present. So, there is no PR interval for dropped beats. Alternating conducted P waves have normal PR interval. The QRS complexes are identical and wide. QS pattern in V1 with RS pattern in V6 are in favor of left bundle branch block. QRS voltage is more than 10 mm in precordial leads and more than 5 mm in limb leads, so the complexes are not low amplitude. None of the criteria of right or left ventricular hypertrophy are present as well, so the complexes are neither low nor high voltage. QRS complexes switch from negative to positive in V6, thereby the transition zone occurs in V6. There are pathological Q waves in D3 as well. In summary, the QRS changes include wide complexes with poor R wave progression due to LBBB and pathological Q in D3. Let's go through ST segment and T wave. There are discordant ST elevations in V1 to V3 and inferior leads. Discordant ST depressions are present in D1 and AVL as well. What about T wave changes? There are prominent T wave inversions in inferior leads. If we take a good look, we find out that there is negative QRS T concordance in inferiors. As we discussed in previous episodes, in presence of left bundle branch block, negative QRS T concordance is generally considered as an abnormal finding, thereby acute ischemia must be considered in this patient. For more information about left bundle branch block, tap the link in right upper corner. In summary, the only abnormal STT change is negative QRS T concordance in inferior leads. So, acute inferior ischemia is present. The ninth step is measuring QT interval. The QT interval is 13 small boxes, so the corrected QT interval according to Hodge's formula is 520 milliseconds, which is obviously prolonged. The last step is overall interpretation. Before going through this part, if you have liked this video till now, please subscribe me and ring the bell. To interpret our strip properly, we are supposed to make a list of abnormal findings. In the present strip, abnormal findings are 2-to-1 heart block, left axis deviation, left bundle branch block, pathological Q wave in D3, negative QRS T concordance, and prolonged QT interval. All these findings are due to ongoing ischemia. According to stages of ST elevation MI evolution, the triad of pathological Q wave, ST elevation and T wave inversion is indicative of post-acute phase of myocardial infarction. So this EKG is demonstrating recently neglected inferior STEMI. Also remember that acute ischemia can interrupt blood supply to AV node and produce different conductive system complications including heart blocks. Again, we re-emphasize that, in context of left bundle branch block, negative QRS T concordance is highly suggestive of acute ischemia, especially when patient's history is suspicious of myocardial infarction. Thanks for watching this video. If you are interested in testing your skills in EKG interpretation, follow my EKG quizzes. Wish you all the best.